I think I am live. Now I am live. Okay. Hello, everyone. I'm going to get my Instagram live here, so give me 1 minute. Getting Instagram live. Okay, that's connecting. Okay, we are live on Facebook and Instagram. Hello, everyone. Happy Saturday. Yeah, sorry to anyone who wasn't anticipating me going live yesterday, but normally I go live on Fridays. Yesterday I took my kids to the pumpkin patch. Hi, people on Instagram. So yeah, doing the live today instead. So just so you know a little bit about what to expect. First off, I'm Vanessa Pruitt. I'm a provisionally licensed mental health practitioner in Nebraska. And the question that I got for today that I'll be answering is, what is borderline personality disorder? So, oops, bumping my tripod here. So, just a little about what to expect today. I'm going to go over what are the diagnostic criteria and the symptoms for borderline personality disorder. And I'll kind of be talking about a little more in depth than like maybe you would just read in the DSM, but a little in depth about what I've seen clinically and what is kind of the cycle of borderline personality disorder, um, and how it can be misdiagnosed as other disorders. I'll also be talking about how um, borderline personality disorder is thought to be related to attachment disturbances and a certain attachment style that we'll get into. Not always, but um, yeah, there's research now to kind of support that theory. And then we will talk about some of the things that a clinician would use to assess someone for borderline personality disorder, and then some of the treatment options and some things to expect for for clinicians to expect and for clients to expect in treatment. Um, so along the way, if I get any questions that pop up, I will try to answer those. But that's a kind of a lot to cover to just today. So some of that stuff might be have to be pushed to another live discussion, but we'll see how it goes. Um, so yeah, let's get started. First things first, I want to start off by saying that when we're talking about personality disorders, um, it can kind of, we have to be really careful because we can kind of get into the territory of it sounding like an attack on someone's character because we're talking about pervasive personality characteristics, or pervasive ways that people relate to others. But I just want everyone to keep in mind that we are talking about a disorder that is treatable, and that having a personality disorder does not make someone inherently good or bad. So, and personality disorders come in degrees, they come on a kind of a spectrum. So, just because someone has a diagnosis of borderline personality disorder does not mean that they're going to look or behave or be anyone anywhere like any another person with borderline personality disorder. Sorry, I'm stumbling over my words. um, So, borderline personality disorder, in a nutshell, is a pervasive pattern of instability in interpersonal relationships, self image, and emotion, as well as a marked impulsivity beginning by early adulthood and present in a variety of contexts. So, these symptoms, behaviors can be seen across different areas of this person's life at work, at home, at school, so on and so forth. And is indicated by 5 or more of the following symptoms that we're going to talk about. So I will read them off quickly and then we'll go a little bit more into each of the symptoms. So the 5 symptoms are chronic feelings of emptiness, emotional instability in reaction to day-to-day events. So this could be intense episodic sadness, irritability, or anxiety. Pattern of unstable and intense interpersonal relationships characterized by extremes between idealization and devaluation. Frantic efforts to avoid real or imagined abandonment. Identity disturbance with markedly or persistently unstable self-image or sense of self. Impulsive behavior in at least 2 areas that are potentially self-damaging. We'll go into what those are. Inappropriate, intense anger or difficulty controlling anger. Recurrent suicidal behavior, gestures or threats or self-harming behavior. And then transient stress-related paranoid ideation or severe dissociative symptoms. So, first one, chronic feelings of emptiness. This can look like depression. It can look like feeling like I am unlovable. It can just look, it kind of goes along with the unstable self-image that we're going to be talking about. The emotional instability in reaction to day-to-day events. So this is intense episodic sadness, irritability, or anxiety, usually lasting a few hours and only rarely more than a few days. And this can sometimes be mistaken for bipolar disorder symptoms, depression, or anxiety to someone who isn't good at sussing out like exactly what these episodes look like. So the sadness or irritability or anxiety, like mentioned, is usually, it only lasts a few hours to sometimes a few days, whereas something like bipolar disorder would look like more of several days to weeks of intense irritability or anxiety or impulsivity. Depression and anxiety, that would be something that is more most days for most of the day, most days. For depression, it would be 2 weeks. Anxiety, it would be 6 months, I believe is the time frame. So when we're looking at the emotional instability related to borderline personality disorder, we're looking at something that's more up and down. So moods being very unstable throughout the day, usually related to interactions with other people and how they have made the person feel. So the pattern of unstable and intense interpersonal relationships, characterized by extremes between idealization and devaluation. This is also known as splitting, and this would be kind of a what kind of a love-hate cycle wherein the person has a tendency to idealize their partner, their friend, their family member, and almost put them on a pedestal, um, never have anything bad to say about them. Um, just really, this person is the most wonderful thing in the world in their mind, followed by a cycle of devaluation where I hate this person is the most horrible person, um, only being able to list bad things about the person. And this is happening in the person's psyche, in the way that in their thought process. And at the end we'll kind of talk about how this kind of comes into a cycle in relationships, and how this kind of plays out in a real world scenario. So then we have frantic efforts to avoid real or imagined abandonment. And this can go along with the impulsive behavior, the inappropriate or intense anger, and the suicidal behavior, gestures, threats, self-harming behavior. Um, so examples of this would be they're afraid, either because of their behavior, because of something that happened, or even just a fear that has come up in their mind that their partner, their friend, or their family member is going to abandon them. As it says, real or imagined abandonment. And examples would be the frantic efforts might be threatening to kill themselves, to try to get this person not to leave them, to harm themselves, so that they're in a crisis and this person, feels more compelled to come back to them and help them. It could be just raging over this person thinking about leaving them, or a fear that this person might leave them. So it can play out in any number of scenarios that are frantic efforts to avoid that abandonment. So identity disturbance with markedly or persistently unstable self-image or sense of self. This one, we often have to be pretty careful, but it can look like changing themselves based on friendships or relationships that they're in, or idols that they have. It can look like frequent switching of gender, sexuality, bodily appearance, and it can go along with impulsivity. So I want to be careful in saying that, because I am not saying that experimentation of self-image, sexuality, gender, any of that is bad or a marker that someone has borderline personality disorder, but it can be a feature, it can be something that we see in people with borderline personality disorder. So I hope that I can make a good distinction there. And remember, we're not talking about like teenagers, where it's a lot, or children where it's more normal, they're going through a phase of life where it's normal to experiment with those kinds of things. We're talking about adults, we're talking about mid 20s, 30s, 40-year-olds, very frequently just not able to have a cohesive sense of who they are. And then we have impulsive behavior in at least two areas that are potentially self-damaging. So this can be spending money they don't have, or spending excessively sex, risky sex, um, having multiple risky sex partners, substance abuse, abusing alcohol and drugs, reckless driving, um, which can a lot of times be seen in their history of being in accidents or causing accidents, binge eating, um, so very impulsive, self damaging behavior. This can sometimes be misdiagnosed or hard to separate from ADHD, bipolar disorder, or other impulse control disorders. So that's where assessment during diagnosis of bipolar, borderline personality disorder is really important because we're really looking at what exactly is this and what we're looking at all the other possible diagnoses. Then we have inappropriate intense anger or difficulty controlling anger. So this can be frequent displays of temper, constant anger, recurrent physical fights. Um, Examples of this would be just uh, never knowing when this person is going to get very angry and throw things around, um, break things, have verbal outbursts, that kind of thing. And then recurrent suicidal behavior, gestures, or threats, or self harming behavior. This kind of goes along with fear of abandonment and unstable self image. Um, so, the suicidal behavior or the self harming behavior can be because of the fear of abandonment, or it could be because of just feeling like a bad person, feeling unlovable, feeling empty. And then we have transient stress. I cannot talk today, guys. Transient stress related paranoid ideation or severe dissociative symptoms. Um, and these dissociative episodes or paranoid ideation are typically related to feelings of rejection or abandonment by other people. So we might see someone having a highly anxious state, feeling like they've done something to which other people are going to reject them, and them going into a state of being severely dissociated, feeling disconnected from themselves, having depersonalization where they don't feel real, derealization where the world doesn't feel real, or they just seem very disconnected from the outside world, or paranoid ideation where they feel like other people are out to get them, everybody is talking about them, everybody hates them. Um, yeah, it can be very specific to the person, but those are the general themes. So the BPT's cycle. The cycle is often one of very intense, quick moving relationships where at first they may very quickly get into intimate relationships, idealizing their partner or their friend, putting them on a pedestal, becoming different for the other person. So they're kind of with that unstable self-image. They are kind of a different person depending on what relationship they're in. And then the emptiness that they feel kind of can play itself out in filling themselves up with the other person's interests, love, attention. And then this goes in a cycle where then it's followed by devaluation, hate, um, which can go with the feeling unlovable. Sometimes there can be a sense of I'm empty and I don't deserve to be loved, so why are you loving me? An anger, a rage. Sometimes this can be um, because the intensity that they put into the relationship is not being received back. Um, the cognitions can be different for each person. There can be an intense feeling that they don't deserve love and pushing away the other person or pushing away intimacy, and so on. So, in this cycle, the behaviors that they have or they express in the relationship, or in general, can lead to the fear of abandonment. So they might fear that because they acted a certain way that this person is going to leave them, um, and this leading to frantic efforts to avoid the real or imagined abandonment, and can to possibly lead to those suicidal behaviors, gestures, threats, or self-harming behavior. The unstable identity and self-image can also be a cycle in that when they're feeling an unstable sense of self is when they have the self-destructive behavior or the self-harming behavior. Um, so I really want to think of borderline personality disorder in terms of an attachment cycle. Because I mean, even if we're not necessarily looking at an early attachment disturbance, or we don't know of an early attachment disturbance, we're still looking at a cycle of attachment, um, because borderline personality disorder typically it plays out in relationships. It plays out in friendships, family relationships, intimate partnerships, workplace relationships. Um, so it can really play itself out in every or almost every relationship that the person has in their life. And that's why it is considered a personality disorder and not just like a mood disorder. So BPD is thought to be related to disorganized attachment style, which is also termed fearful avoidant. So I have other tabs, so I'm just seeing if I had any viewers on Facebook, and I have one. So just, yeah, along the way, pop up if you have any questions or just say hi. Okay. Um, so with disorganized attachment, so there is research to support that there's a link between borderline personality disorder and people with disorganized attachment style. That's not to say that everyone with borderline personality disorder has a disorganized attachment style, and most certainly not vice versa. Like if you have a disorganized attachment style, does not necessarily mean that you're going to have a diagnosis of borderline personality disorder. But with disorganized attachment, the primary caregiver in the person's life, and this is typically before the age, this is birth to 2 to 3 years old. So this is a very, very young, is when we start to solidify our attachment style. And with disorganized attachment style, a primary caregiver may have been abusive, volatile, extremely neglectful, and their attachment needs were not fulfilled or not consistently fulfilled by the attachment figure. And they often learn that the attachment figure is not safe. Um, so yeah, just to reiterate, The disorganized, fearful, avoidant attachment style develops when a child's caregivers, which is supposed to be their source of safety, becomes the source of fear. Um, and that's in general, but it's pretty specific to disorganized attachment rather than anxious, avoidant, or avoidant, is that the attachment figure who was the source of comfort and safety was also the source of fear. So the person's caregivers likely showed very highly contrasting behavior. They were inconsistent, unpredictable, um, and the child often feared for their safety, their own safety. It can also happen if they witnessed their caregiver um, hurting someone else, so they were still fearful of their caregiver because they saw that person being abusive to someone else. Um, so, in essence, the person learned as a child not to know what to expect in attachment relationships. Um, and that their attachment figure wouldn't consistently meet their needs, if at all. Um, and in adulthood, tend to lack a coherent approach towards relationships. So they want to be loved, but at the same time, they're fearful of the attachment, fearful of the person that they want to be loved by. They fear that people close to them will hurt them, and they expect rejection, disappointment, and hurt. So, if you really think about this, like if you were putting borderline personality disorder and disorganized attachment disorder side by side, it really starts to look very similar, right? And so, and it is like us, we're looking at the behavior manifestation of what it would be to have such a volatile attachment to your caregiver when you were very young. So there's often a fear there's a longing for intimacy that comes along with a fear of intimacy. So they long to be in a relationship, but they have behaviors that avoid emotional proximity. And I just want to read off from attachmentproject.com, had 10 signs of a disorganized attachment in adults. I want you to kind of think about the symptoms I gave for BPD alongside these signs of disorganized attachment. So it's 1, unable to regulate emotions. 2, strong fear of being hurt, rejected, abandoned by loved ones. 3, chronically vigilant and anxious. 4, low self-agency, a sense of not having an impact on the world. 5, feeling ineffective and helpless in life. 6, poor goal-oriented behavior. 7, difficulties with bonding, opening up to and trusting others. 8, showing contradictory behaviors in intimate relationships. Quote, I hate you, don't leave me. 9, alternating between clinginess and aloofness. And 10, exhibiting characteristics and behaviors of the other 2 insecure attachment styles, which are dismissive and preoccupied, or anxious and avoidant. There's too many. Each attachment style has like 2 different names depending on who you're talking to. So, if you want to know more about attachment styles, I'm planning to do a live Q&A on the different attachment styles. I'll probably do one on each eventually. But if you want to learn more now, I really highly recommend attachmentproject.com. And also on there on the top right, you can take an attachment style quiz and find out what your attachment style is. And they have lots of great information about your attachment style once you get the results. So, let me check here, see if anyone had any questions. Yay, Judy. Judy on Facebook said, "This is really informative. It's blowing my mind a little." That's awesome. Um, yeah, I feel like, yeah, I was really excited to share this information because when it was really mind blowing to me when I started to learn about it, I was like, in a master's degree, when we're learning about personality disorders and stuff, like we really don't, we learn about what BPD is and we learn about personality disorders in general, but we don't learn a whole lot about what that actually looks like in real life or go into depth about any of the new research about attachment styles and all that. We don't really go into attachments much in our clinical training. So clinicians in general kind of have to seek out what areas they want to learn about and specialize in. And so the information out there, it's just all over the place about what people are informed about. But I love spreading information about attachment styles. And I think that when we're talking about borderline personality disorder, especially, we'll get into like some of the assessment and treatment, but especially in treatment, we're really missing the mark, I think, and I'll talk about if we're not addressing attachment. Like if we're just addressing the surface issues and we're not addressing the underlying issue, which is that there was these huge attachment breaks that happen, and that's the reason why this person is playing out these attachments in their adult life. So anyway, um, let's jump into assessment. So I'll just briefly about assessments. Um, Assessments for borderline personality disorder are very varied, depending on where you are, depending on what kind of assessments you have access to. Um, so I did my internship at Wichita State University, and I was really lucky. We had the ability and the access that I learned how to do pretty thorough assessments. So we would do an intelligence test, we would do personality tests, we would do in-depth clinical interviews, psychosocial history, behavioral observations, embedded tests of malingering, which is telling if someone is either unconsciously or consciously misrepresenting themselves or their symptoms or what's going on. Projective tests, which I was trained to do a projective test, but we didn't do a lot there. And then sometimes clinicians will include interviews with friends and family members. So all of that together would be like the most in-depth psychosocial or psychological evaluation. In practice, unless someone has access to they can pay for an in-depth psychological evaluation, and B, they can find someone in their area who can do that in-depth psychological evaluation, um, then the reality is a lot of people don't get that full psychological eval. Um, Sometimes people are diagnosed in inpatient treatment because they've had suicidal, because they've attempted suicide, or their self-harming behavior was bad enough that they were put in inpatient treatment. But if it if that person has never had inpatient treatment, um, yeah, it's a little trickier. So I would say the bare minimum for a diagnosis of borderline personality disorder is because some clinicians at the master's level, which is what I am, are not able to do intelligence tests and personality tests. Um, so the bare minimum would probably be an in-depth clinical interview along with a psychosocial evaluation or psychosocial history, behavioral observations. If they can do an embedded test for malingering somehow, that's great. If they can do some projective tests, that could be helpful. And then if they can do any interviews or questionnaires with friends and family members. um, so yeah, we're really looking for what are all of the symptoms, what is the full background of this person, and we're also looking to rule out other possible conditions. So, like I said, we could be ruling out ADHD, bipolar disorder, other personality disorders, depression, anxiety, um, autism, even. We could be kind of ruling that out. Um, so, yeah, that's just a note on assessment. If anyone has any like specific questions about assessment, I can try to answer that. So just let me know in the chat. Otherwise, I'm going to go on to treatment. Um, so the biggest question usually for treatment is it possible to treat someone with borderline personality disorder? Like, is this something that people can um, what is the right wording? Like, can someone with borderline personality disorder go to treatment and then be considered to no longer have borderline personality disorder, or considered to be like have returned to a level of functioning where they would no longer meet the criteria? And the answer is yes, it is possible. Um, there's a lot of caveats to that. um, so first, just little note about what are some of the treatments. So for the treatment of borderline personality disorder, we're looking at three main treatments. DBT, which is dialectical behavioral therapy, and this teaches behavioral skills, mindfulness skills, and cognitive based skills in order to lessen some of the distressing behaviors and um, start having better functioning in daily life. Then a little bit slightly less researched, but the research that has been done has shown that is as effective or more effective than DBT, which is mentalization based therapy. And mentalization based therapy, which is also very effective for attachment disturbances, it's helping the person really think very metacognitively about their behaviors, how they affect other people, how they're affecting their life. It is a very in depth, sometimes laborious process, but it's the reason why it's so effective is because with attachment disturbances or with caregivers who were unpredictable or unstable, we weren't taught the mentalization techniques when we were very young. Um, so there wasn't that relationship there that taught us to think through and analyze and understand ourselves and other people and our behavior and the way we work in the world. Um, that's a summary. I don't know if I really explained it that well, but you can kind of look up some of the definitions of mentalization based therapy or mentalization based therapy. And then we have attachment based psychotherapies, which are really based on healing those core attachment wounds. And some of the attachment based psychotherapies that I've done training in also utilize mentalization based therapy. So that's usually a part of it. And then there are things like somatic work, visualization, um, like creating safe spaces in our mind and creating ideal attachment figures that we can use as substitutes for what we had when we were very young. So it's yeah, some of it's like not rewiring. That's not a good word, but like um, creating new memories, creating new ways of uh, narrating, conceptualizing our attachments. So also very rooted in like narrative therapy. And then other methods come into play like action and commitment therapy, which is ACT, CBT, cognitive behavioral therapy, and solution focused. And usually those are used more in the trying to get people to identify the issues that they're having and what we call buy-in to therapy, like that therapy is something that can help them. Um, so yeah, segueing right into buy-in to therapy, it's very important because in personality disorders can be difficult to treat if the client is unaware or is in denial of the the issue. Like if the blame is on everybody else and they're not seeing any of the problems with their own behaviors, it's very hard to treat that person. A lot can depend on how the person was brought into treatment and what state of change they are in, um, and also how able and willing they are to be open and honest with a therapist. So, if someone was forced into treatment because of a behavior that they had, or um, they are in really they are in therapy for a different issue, then it can be a lot harder than someone who maybe came into therapy for the purpose of saying, I have all these relationship problems, um, and having a little bit of an understanding that they might be a little bit of part of the problem, I say lightly, but uh, yeah, that they have more of an understanding that this is something they need to work on. Um, so therapists who work with people with borderline personality disorder should be skilled in assessing where a person at, like what is their state of change. Are they don't think there's a problem, they don't want to change, or are they at the point where they're thinking about maybe I need to change, or are they like, yeah, I got a problem and I need to change? How much insight do they have into their own behavior? And do they demonstrate an understanding? Yeah, the therapist should be able to demonstrate an understanding of being able to work from where the client is at. So if they're at the point where they're not sure if they have a problem or they really don't think they have a problem, it's going to be a process of building rapport with that client and gently leading that client to an understanding that maybe they have things that they need to change and kind of get them to buy into treatment rather than immediately beginning with, you have borderline personality disorder, um, and we need to do this in-depth psychotherapy, because that person's not going to think they have a problem and they're just going to drop out of treatment. Um, there should be a pretty thorough investigation as far as the person's willing to be open and honest of trauma history. Um, that's another thing also we're looking at, is this uh, PTSD, complex PTSD, BPD, or a combination of those. But also looking at the attachment trauma. And so this should be assessed and taken into account. Um, there can be a very high degree of transference and countertransference in therapy. So what that means is that because this is a pervasive personality disorder, this can look like the client playing out that attachment cycle, that borderline cycle with the therapist. So this can look like them being a fear of abandonment, of the therapist abandoning them, anger at the therapist, reactivity to the therapist, impulsivity because of something that happened in therapy, an intensity of attachment to the therapist. So, on one hand, this can make this a very difficult thing for some therapists to treat. On the other hand, this can be used as a tool for treatment. So, it's there are therapists that they are not comfortable working with clients with borderline personality disorder. And I think if it comes from a place of really examining and understanding themselves that they are not a good fit for that client, because it brings up all of their own attachment stuff and they are not able to separate that transference and countertransference or deal with that, then that's probably a wise choice for both the client and the therapist. But if there's a therapist who is able enough to separate themselves from that and to use that as a tool in treatment, then that can be a really great thing for the client. Um, and then just like, not to end super abruptly, but to just wrap that all up, um, is just to say that if someone with borderline personality disorder is open and willing to be honest, um, is able to get to a place where they understand that there's an issue and that they want to change, that treatment can be very transformative and effective. Um, so that is kind of the whole shebang about what I wanted to talk about borderline personality disorder. I'll wait for just a minute to see if there's any follow up questions. Or if you just want to pop in the comments and tell me what you're doing today. I just a little bit about my day. I've had a heck of a week, let me tell you. But um my it's been like 39 degrees. It's I think last night it got down to like 39 degrees at night. And I have no heat. So the last few days have not been too bad. I knew my heater wasn't working and my landlord's been trying to get someone out. The word now is I need the heater needs replaced, so I'm waiting on that. But, last couple of days were fine because it got up enough during the day to warm my house up a little bit to like 70, 71. But it got really cold last night and it has not warmed up today, and my house is cold. So this has been me today and my sweater, my coffee, and just trying to stay warm. So, well, I don't see any questions. So I hope you guys all have a great Saturday. Enjoy your time. And I will see you guys next week. Bye. Bye, Facebook. I gotta end both. Bye.